Here's another example where you can reduce your dose. This patient has a neck mass, looks like it might be an abscess. Did you really need to scan into the nose and the brain in order to evaluate this thing that the patient could point where it was? You can place a marker and just scan a little bit above, a little bit below to get the information you need. And of course, the CT acquisition parameters. Perhaps this is the most intimidating for people because you have to dip into your physics knowledge. I would say it's really not that big of a deal. You talk it over with your technologist, you talk with the manufacturer to help make some prudent decreases in these things, increases in these things, do it a little bit of a time, and you will get your doses down. Dialing down the number is easy. You just enter it into your scanner settings. The hard part is the initiative and the intimidation of, oh man, I don't want to break something and maybe I'll mess up the numbers for the next patient. So just take it slow, drop the numbers. I'll show you some example numbers that we use for our kids. We have a weight-based algorithm. So for little babies to big teenagers, and above this, we don't increase the dose anymore. We say this is as much dose as we're going to give. We have a range of about 80 kVp up to about 120 kVp. Interestingly, we found empirically that at the 80 kVp, we have to give the scanner a little bit more milliamps to work with. So we give it up to, if it needs it, 250. But that at 100 kV, we only give it a max of 100. And then we ramp that up as your age increases. So you kind of slowly increase kVp and you a little bit more quickly increase your MA maximum dose. We have a scanner that will reduce the dose if it can, but we set as an upper ceiling, do not exceed this milliamp. So these are numbers that we use based on phantoms that we've done in our own tests. You might have slightly different setup at your institution, but at least to have this set up for kids so that they're not always getting the highest maximum dose meant for overweight adults. Because you put those doses into little babies, now you're talking about really high concentration unnecessarily of dose in terms of image quality. This is what we have found gives us enough image quality that we can stay diagnostic with minimizing the dose. We'll talk about how we've gone too far on the dose, and I'll show you examples of that. Okay, what about indication-based dosing? What if you have a protocol that's a low-dose protocol? So we have an ultra-low-dose protocol that we offer for airway foreign bodies, for pectus excavatum, or for maybe kidney stones. You don't need as much dose to see those things because you have inherently high contrast between air and calcium and soft tissues. And then we have our standard dose that we'll use for other conventional things like infection, inflammation, or tumor. So we have two different protocols depending on the indication. Automatic exposure control is something that may or may not be present on your machine. If it is present, what it is doing is it takes the scout and it says, okay, what am I going to need to give in terms of energy on a slice by slice? So at the level of the shoulders, I'm going to need to go a little bit stronger. Through the chest, we can kind of dip down the dose a little bit, but then when we get back to the abdomen, we got to crank the dose back up again. Now be aware that because it's based on the scout, if you move the arms midway through, the scanner can't figure that out on the fly. So if you scout with arms up, but then CT with arms down, you may get a lot of streak and you may not have sufficient dose to get your images because now your arms are in the way. Conversely, if you start with your arms down, it'll say, man, we have to get through those elbows. We better crank up the dose. You put your arms up, the scanner doesn't know that it didn't really need that much dose. So you should kind of have your patient set up the way you want. Now, some people will play tricks on the machine. It'll not place a breast shield for the scout so that the scanner says, okay, I don't need to give too much dose through the level of the breast. But then when you actually scan, you do put on a breast shield because you want to protect it. If you did the reverse, if you put the breast shield on first, then the computer would say, oh, look at this density of lead here. I need to increase the dose, and completely undermines your attempt to reduce the dose to the breast. So something to be aware of. If you have automatic exposure control, it is based on the scout. Image quality selection. This is an idea where you can tell the machine, look, you do the math, you figure out what dose it needs to be. I just want the image to look as good as a certain index reference. And depending on your manufacturer, that could be a number called noise index for General Electric, or it could be an image that you upload to say, I want it to be at least as good as this in terms of noise. I don't want it any noisier, and you increase the dose accordingly. So you kind of tell the computer to do the work for you. So we're now going to finish off. We've understood doses with review. We've talked about lowering the doses. Well, let's say we've lowered the doses too much and the pictures are starting to look bad. That's where reformat will save us. Reformat will take crummy, noisy-looking images and make them look good again so that we can all be getting the diagnostic information we need. So there are different CT reconstruction algorithms out there. The standard that is used on all scanners as a default will be filtered back projection. A fancier mathematical reconstruction will be statistical iterative reconstruction, and an even fancier, most recent reconstruction is called model-based iterative reconstruction. This one, which is the latest and greatest, depending on what study you read, you have noise reduction of anywhere from 31 to 79%, allowing a dose reduction of 50 to 99%. And that 99% may sound absurd, but I'll show you an example of where that's actually not such a crazy number in terms of the amount of dose that you can get away with reducing. And again, it's not that these algorithms directly reduce the dose, it's that they take a low dose study that looks bad and make it look better. So I'm not going to go into the math because these are all going to be black boxes, but this is how filtered back projection works. You take your data, you plug it through filtered back projection, you get your image. Here it's ahead. It's a little bit noisy, but you know, we can kind of make out what's going on, so we're fine. Statistical iterative reconstruction is the fanciest mathematical. I'll show you where these curvy lines saying that the data iteratively looks back at itself and then recomputes how it should look. And again, that's what iterations means, gives you a better looking head. It's a bigger black box than filtered back projection, but the biggest black box of all will be model-based iterative reconstruction. This takes about an hour on really fast computers. So you can't get this image, which now that looks pretty good. You started kind of bad, but now your same CT data is looking pretty good, but you had to wait an hour to get it. So this is not going to be a great solution for a trauma emergency patient, but it's a great solution for an outpatient or someone whose data you're willing to wait for. Model-based iterative reconstruction and statistical iterative reconstruction are different manufacturer names out there, depending on what you're talking about. So different companies do offer this, and they all have, of course, their own special name for it. So let's show some examples. These are phantom data. This is filtered back projection, FBP. And if I asked you to find the lesion, you'd say, I don't know. I mean, are you looking for black spots or white spots, or I don't know. It all kind of looks the same to me. But then you apply model-based iterative reconstruction. What it does is it eliminates noise and brings out what is a true lesion. So now you can actually see something coming, and you look back and, okay, I guess I could sort of make that out, but now it's pretty obvious when we've used this reconstruction. Let's look at an actual patient. This is filtered back projection. We have some contrast in the bowel, but otherwise I don't really see anything too remarkable going on here. But we do a model-based iterative reconstruction, and now it's almost like turning the lights on and, hey, what's this thing? That's a little distal ureter stone that I guess, okay, it was this little dot here, but I couldn't really distinguish that dot from all the noise around it. So the reconstruction took noisy information and made it better, made it diagnostic. So these reconstruction algorithms, what do? They reduce noise. So filter back projection at higher dose, you'll have less noise, and the better reconstruction algorithm at any given dose has lower noise. And so model-based is the best. And notice, though, that the best reduction is going to be at low doses. At low doses, you have really high noise for filtered back projection. If you give enough dose, everyone can do fine. They all kind of converge, and you have low noise down at this side of the graph. So your reconstruction algorithms, they only sort of earn their keep when you're dealing with the low dose range. So let's look at statistical iterative reconstruction versus model-based iterative reconstruction, and we'll look at regular doses. So this is an actual patient, and this is zoomed up, so it looks like nothing, but you get a sense that, okay, it's kind of noisy. I can't really tell what's real and what's fake. I did model-based iterative reconstruction, and it kind of looks the same. I can't really tell the difference between these two. So this was actually what it was. It was lung. I was looking at lung tissue, and this is statistical iterative reconstruction. Okay, it's a little bit noisy. This is, normal. And this is model-based iterative reconstruction. And if I didn't tell you the fact that I just changed the slide, you can't really tell the difference between these two. So at higher normal doses, you can't really tell the difference. The model-based iterative reconstruction doesn't really do anything for you at the regular doses. So you have to be the one that turns the dose down. So what about our ultra-low dose protocol that we have? Now how will these compare? So this, at ultra-low dose, the statistical iterative reconstruction looks kind of crummy. I mean, I can't tell what's real and what's fake here. But model-based iterative reconstruction, we're actually seeing a little bit of architecture, and it looks a lot better. So now I can actually tell a difference at this ultra-low dose. And this is where the information is coming from. This is a lung at ultra-low dose, and you can tell even the air is noisy, not just the patient. And are these nodules, are these vessels, just noise? You can't tell. It's too grainy. But now you put on the model-based iterative reconstruction, and oh, this actually was either a fissure or a vessel, that the reconstruction method is able to discern better what is reality and what is noise, what is reality and what is artifact. So this is not too bad. And yet we're using such a small dose. So this is our ultra-low dose chest CT. We developed it actually for pectus excavatum, but we're now using it for cystic fibrosis follow-up. We also use it for excluding airway foreign bodies. And these are just kind of fun, eye candy 3D reformats of that data. This is a DLP of 6. If you remember early on, and I'll tell you again, I said for kids kind of stay under 200. This is a DLP of 6, so that, remember we talked about 99% dose reduction? It sounds absurd, but if you find the right application, like an ultra-low dose chest CT, and then you use model-based iterative reconstruction to make the images better, that's when you can achieve really low effective doses. So this effective dose is the same as a PA and lateral chest X-ray. You've been able to get chest CT data at chest X-ray doses, which is pretty amazing. I would much rather look at this than a chest X-ray if I had to pick. Not to say that we should be doing that uniformly, but just something to kind of think about. Okay, I talked about pushing the dose too low, and that was going to be one of my take-home messages. You want to see at some point in your practice that you're pushing the dose aggressively low enough that you get to some situations that look like this, where, I don't know, is this cirrhosis? Is this infection? Is this cancer? Or is it just noise? This is at a DLP of 40. I said for kids, stay under 200. 40 is well under 200. This is the same patient. Scan at DLP 80 a few months later. Liver is totally normal looking. This was all just because the dose was too low. So in our practice, we basically pushed the doses until we got to this point, and then we dialed them back up again to get them back to here. So these were the numbers I would have you keep in mind for DLP. Again, this is in units of milligrade centimeter. Less than 200 for kids, less than 500 for adults. These are just, guidelines. If you were to go back and say these numbers are absurd, I can't actually achieve this, then good, because you've thought about it, and I've succeeded in getting you to think about this topic. Let's be honest with what is UCSF data in year 2015. Here are DLP marks. 200 I said I want for kids, 500 for adults, 1200 is just the highest that this graph goes. These white bars represent the 75th percentile, so the majority of our data. And these are all 0 to 18-year-olds. So these are all kind of kids, big and small. And we've done a pretty good job of keeping under 200. Now, I don't have control over the spine CT because I actually, as a pediatric radiologist, do more of the body work and the neuroradiologists do the spine. That being said, probably a lot of this is coming from the studies where they're looking for the artery of Adamkowitz and they're probably juicing it up, making it kind of hot. It's still less than 500, so not too bad. IR, it's kind of hard to avoid procedures if you need a long scan time. So really, I'm kind of targeting these kind of things here that I want to stay under 200. So we've been able to do it, and I feel proud of that. Let's look at our adult data, 18 to 100 years old. I said try and stay under 500. I don't have control over my adult colleagues who are, or my colleagues who are dealing with adult patients. they're pretty uniformly over the benchmark that I think that we could try and be lower than. So they might disagree with me on this number, but I would say a lot of the abdomen numbers are high because of multi-phase scanning. See a lot of liver cancer here, so we're getting a lot of liver scan multi-phase, so maybe it's not fair to use 500, just think of it perhaps as a single phase benchmark. But again, pick a number. It may not be 500, but at least have a number so that when you look at each study and dictate it out, that you're understanding where you stand study by study. Okay, so we've talked about understanding the dose, we've talked about lowering the dose, and then we've talked about taking low dose data and making it look better. The take-home message I will say again was, don't be afraid of seeing this. You kind of want to see a study that looks bad because you know you've pushed hard enough. It reminds me of when I was rotating through the intensive care unit, and one of the attending physicians told me, if you've never had failures and having to reintubate patients that you just extubated, if you're never having to reintubate, then you're not extubating soon enough. That you should accept a small failure rate to know that you're right at the appropriate threshold of when to pull the trigger. So if your images are never too grainy, if you've never seen this before, then you haven't even probably tried to start dropping your doses. Don't be afraid of seeing this. If, one patient, yes, it causes some confusion, and then you react to it. Perhaps that's better than being so slow and so incremental in your dose reduction that you never actually make it to this point. So I have some questions. They are going to be included in a test that was sent to you. So I will review some of the answers here. Choose as you may to stop the lecture or whatever you decide and take your test, but here are the answers and discussions. So all of the following will directly decrease radiation dose except what? So if I decrease, if I play with automatic exposure control, yeah, I can tell the machine to lower the dose, and that will directly decrease the dose. If I decrease the KV, yeah, that'll decrease the dose. If I decrease the MA, yeah, that'll decrease the dose. Model-based iterative reconstruction, it doesn't directly decrease the dose. Remember, you have to be the one that chooses to reduce the dose. The reconstruction simply makes the images better. It kind of saves the data, if you will. And if you still have trouble kind of remembering what model-based iterative reconstruction or any of these reconstruction methods mean, have you take this example. Iterative reconstruction takes crummy-looking noise and brings out the truth. And for those of you who don't know the reference of these images, it's actually quite funny. This was a overzealous church attendant who decided that she would try and make this look better. This already looks really good, but she wanted to make it better and actually made it look like this. So reconstruction methods are the total opposite of what that lady did. They take this and they bring out the truth. Question 2, all of the following are complaints about model-based iterative reconstruction, except I can't tell the difference at normal doses. Yeah, again, you have to be the one that drops the dose. It doesn't do it for you. Images look waxy. They kind of do. It has a little bit of a weird look. You have to get used to it. Only available from one vendor? No, they have several vendors out there. Processing takes too long? Yeah, it takes a long time. It takes about an hour. So what was the except? This was the wrong answer. Or this was the right answer because it was not something that's a complaint. What parameter is multiplied by a conversion factor to calculate effective dose? Okay, so that was the thing that I told you was the most important thing from this lecture, the thing that's in milligray centimeter. You multiply it by the conversion factor, which is in millisieverts per milligray centimeter. That's going to be your dose length product. You multiply it and you get it to your cancer risk. It's the thing that's going to be on your report because effective dose will not be. If you ever wanted to get that, you would have to manually look up that table, look at your DLP, know what the body part was, what the age of the patient was, and do it yourself. The computer does not do that for you. It will, however, give you the DLP, which is why I think that's what you should be looking at on every dose, on every study. Question 4, which of the following states? This is only pertinent to the United States. Turns out that Tennessee does not require, California, Connecticut, and Texas do. So these were the numbers. Once again, they're not perfect, but they're guidelines. And if you have feedback for me, I'd be happy to hear about it. Kids try and stay under 200. Adults stay under 500. And again, this is for abdomen, pelvis, single phase. So seems maybe intimidating. Where do you start? Well, again, just start by knowing what your doses are. Look at the dose report on every study. And then when you make changes, just do a little bit at a time. Here's some tips also based on our experiences. Have one person in your group in charge of doing this so that they can keep track of, the changes and also the goals. If you have multiple CT scanners at different hospitals, I would say make small changes for all of them at the same time. Otherwise, you'll quickly lose track of what you're doing across your different sites. If you have lots of partners who may all complain about how noisy things are starting to look when you start dropping the doses, probably better to just ask for forgiveness than permission and just do it rather than say, oh, do you mind if I drop the dose on your study? And they say, no way, I want my dose really high. So sometimes just do it. They may not even notice that you did it. These are online resources that are out there to go over even more in-depth review of this topic. And that is it. I chose this animation from a spot where I like to go bicycling to represent this lecture, which was originally going to be cast live. This is the sun rising over San Francisco as it is setting over your country. So hopefully next time when we get the AV stuff worked out, I will be able to give you guys a live lecture next time. Thank you so much.